Alex mentioned CMS's leadership in this transition to value-based care, and we're honored to have Lara Strawbridge with us today. She's the Oncology Care Model Lead in the Patient Care Models Group at the Center for Medicare and Medicaid Innovation, and she's leading this team that Alex mentioned that's been implementing the OCM, and she joins us today to share an update on that program. Lara?
Great. Thanks, Catherine, and good afternoon, everyone. I'm happy to be with you this afternoon virtually anyway. Just a brief overview of the CMS Innovation Center for those of you who may not be familiar. We are called sometimes CMMI or the Innovation Center. We were created by the Affordable Care Act, and our purpose really is to design and then test new ways of paying for health care and then also for delivering that health care for the beneficiaries that receive health care through CMS. So that would be Medicare, Medicaid, and CHIP. Our priorities are really, again, to develop new models, to test them, and to evaluate whether or not they work, and then in cases where they do, potentially scale more broadly, and also to engage a range of stakeholders to think about future opportunities. Overall, all of our models are aimed at a central goal that's outlined in the Affordable Care Act of reducing program expenditures while preserving or enhancing the quality of care. So we have models that range in focus from ACOs to primary care to bundled payments and state innovation. And of course, today I'll be speaking specifically about the oncology care model. So a few of the estimates on this slide were really already covered by Alex just a moment ago, but as you all listening today are likely well aware, we have millions of Americans being diagnosed every year with cancer. We have hundreds of thousands dying, and a significant portion of that population with cancer is the Medicare population. So not only that, but we have costs that are high, they're rising, and they're variable. So within CMS, we identified that oncology was an area of opportunity for us to try and achieve the goals that we do with all of our models, which again is to improve care and outcomes while doing it at either the same or lower cost. So the oncology care model has a focus on episodes of care, and I'll talk more about those in a moment, that are focused around Medicare beneficiaries who have cancer and who are receiving chemotherapy. And our goals for the model are to try and use financial incentives to improve care coordination, appropriateness of care, and also access to care. And again, the hope is that by having financial incentives that support these three goals, that we can then also improve overall quality of care, health outcomes, and either maintain or reduce costs. So I'll speak about the financial incentives in a few minutes, but the goal is that the financial incentives will hopefully encourage the participants that we work with to collaborate within their practices and also with providers outside their practice to really create a model that comprehensively addresses the very complex healthcare needs of patients who are receiving chemotherapy for cancer. So a few basics of the model. As I mentioned, for each individual that's part of the oncology care model, they are part of it through an episode. So we target chemotherapy and then the care that follows during a 6-month period of time. So it begins with a patient receiving chemotherapy and Medicare receiving that claim, and then continues for a 6-month period of time after that. Our goal is to most essentially emphasize the idea of whole practice transformation, where the practices that we are participating with implement practice redesign activities that will help them improve their quality of care and really transform the way that they do their business. As Alex mentioned a few minutes ago, we're a multi-payer model, so we I am obviously representing the Medicare fee-for-service piece of the model, but we do have other payers working with us. And again, the idea here is the whole practice has an incentive to transform if you have not only your Medicare population, but also other payer populations included as part of the model. So we started last year on July 1st of 2016, and we'll go for 5 years. So we're about 14 months into the model at this point. And throughout the next few minutes, I will mention some anecdotes that we're hearing based on early implementation experience, but I do want to emphasize that we don't have any actual results yet. The evaluation has begun, but will be ongoing, and it will be some time before we can say definitively what has happened in OCM. Much of the initial year of the oncology care model, we at CMS were really focused on providing information that could help assist our participants with implementation of the model. So we were focused on the requirements and operational details of the model. We certainly continue to provide that support to our participants, but we also are really trying to put an emphasis now on sharing best practices among our participants and helping them understand and identify where opportunities for improvement might be. So it's an exciting time for us. As I mentioned, we have certain required activities that each of the participants we have in the model must do to participate, and we call them practice redesign activities. The first one is a broad category which involves 4 main components. So we say practices must provide enhanced services, and those are 4-part. One is to provide the patients that are part of the model with 24/7 access to a clinician who has real-time access to the medical record of that patient. The second is to provide core functions of patient navigation to those beneficiaries. The third is to document a care plan that contains 13 different elements that were recommended by the Institute of Medicine. And lastly, they must treat the beneficiaries that are part of the model with therapies consistent with nationally recognized clinical guidelines, or if they deviate, they must document a reason why they have deviated. In particular, I want to just highlight the third item here on the list for a moment, that documenting a care plan. I do want to note that this item out of all 4 of these, I think, has provided the biggest challenge to our participants so far. In particular, there's an element that requires that practices provide patients with an estimate of their out-of-pocket costs of care. And it's been a challenge for practices. We've worked with them and with some experts in the field to try to identify the best way to do that activity. But we have been hearing from folks anecdotally that the care plan in particular as an activity is one that they believe is improving their care as a result. In addition to those enhanced services, we have 2 other required activities. One is to use certified electronic health record technology, and the third is to utilize data for continuous quality improvement. So to elaborate on that last one for a moment, I'll say that we ask practices to collect and report on clinical and quality data to us, and I'll talk about some of the measures that we require in a few minutes. But in addition, we do provide our practices with feedback reports that are based on claims data and some other sources of data as well, such as patient surveys, to give them information to identify where those opportunities for improvement might be. We also, in addition to the feedback reports themselves, which include measures around utilization, cost, patient experience, and end-of-life care, we also provide practices with the claims data that underlie those reports so that those that are interested and have the analytic capabilities, they can really dig in and see the specific services and other care that their beneficiaries are receiving. I will note that EHRs and health IT have been a challenge for our participants in our model. It can take time for EHRs to adjust to the requirements that we have put out, and also for them, the EHR vendors, to adjust to the requests and needs of the practice as well. So there's time required for implementing the changes that we have here in the oncology care model. There's also, in addition to the technical changes that are often required, a need for a culture change where providers are really using the new fields, in particular structured fields, that EHR vendors might create for them to use. So we've been working not only with our practices, but also with EHR vendors through a work group to try to improve the ability of practices to collect data for the oncology care model and then also to report some of those elements to us. So Alex covered some of these numbers again a few minutes ago. I won't spend much time talking about the practices themselves other than to say we have nearly 200 practices participating. All of them are treating patients with cancer who are receiving chemotherapy, and they are located in a range of geographic areas and range in size. We have an incredibly heterogeneous group. We have solo practitioners, and we have large practices with hundreds of providers, and Alex noted a couple of them on his slides as well. We've heard from practices of a number of focuses that they've had early on as a way to try to improve their care and potentially reduce costs. Some of the efforts have focused on avoiding hospitalizations and ED visits. Some practices have used triage phone lines or care coordination and risk stratification through team huddles, through navigation and other activities. Some practices have established same-day and walk-in appointments. Others have extended their hours in the evenings or weekends, or made arrangements with nearby health centers for urgent supportive therapy. Other practices have conducted proactive outreach to high-risk patients. Some practices have focused on palliative care as an early area to concentrate on, including managing pain, advanced care planning, and the emphasis of advanced care planning happening early and often, and also on survivorship planning as well. So we have a lot of exciting work happening among our participants. We also have payers participating. As I mentioned, this is a multi-payer model, so we have 14 commercial insurers that are supporting OCM practices. You may have noticed that Alex mentioned 17. We do have 17 participating, but 3 of those payers are all Blue Cross Blue Shield payers who have decided to band together under their partnership with the Healthcare Services Corporation and collaborate through that lens. So we can say 14 payers, but they together are working with us to provide that financial incentive and also emphasis on quality measurement to try to support whole practice transformation. So we and the other payers that are participating in the oncology care model convene regularly to share lessons that we're learning and brainstorm solutions to issues that inevitably come up throughout model implementation. We ask that payers that participate in the model align with us in a number of ways, including the 5 ways that are outlined on the slide here. So we ask that they provide services, payment for enhanced services and also for performance. We ask that they include at a minimum patients receiving chemotherapy as a focus. They can include other kinds of patients as well. We ask that they require similar practice redesign activities as I outlined a few slides ago. We ask that they share data with their practices that they work with and that they align with us on a core quality measure set. And I'll give a quick overview of some of those quality measures in just a moment. So we have a 2-part payment approach in OCM, and again, this is the financial incentives that I've been mentioning. So we have a monthly per beneficiary payment that we make prospectively to our practices for the patients that they're caring for who are in Medicare fee-for-service. And then we also have a retrospective possible performance-based payment that practices may receive if they achieve high-quality care and also reduce expenditures below a target price. We have 2 different risk arrangements in OCM. So we have a one-sided non-risk-bearing option where practices are not responsible if expenditures increase during the model. And then we also have a two-sided model where practices are asked to assume some risk, and if expenditures exceed the target, then they could be responsible for paying money back to CMS. There are some additional details on this slide. I won't go into them, but feel free to refer to them, and if there are questions during the Q&A, I'd be happy to answer them. The one thing I wanted to point out additionally here, though, is that both one-sided and two-sided risk in the oncology care model are considered APMs for QPP, or quality payment purposes, the quality payment program, excuse me. So our one-sided is considered a MIPS APM, and two-sided risk is an advanced APM. So we have a number of quality measures that affect practices' ability to earn a performance-based payment in the oncology care model. We have 3 that are claims-based, 1 patient-reported survey measure, and then we have 8 practice-reported measures. All of the measures in total have a range of focuses, including utilization of services, end-of-life care, patient experience, measures around symptom management and psychosocial care, also care coordination, and then quality and timeliness of care. And as I mentioned earlier, practices also report to us, in addition to the 8 practice-reported measures on this slide, a range of clinical and staging data, which we are hopeful will enable us to create more narrow bundles going forward for calculating target prices. So we have a learning community in the oncology care model to help support our practices. It's a robust effort to try to share best practices and support practices in their implementation. We have a range of activities, from webinars to online collaboration to affinity and action groups, which are smaller groups that meet together and really dig into an issue such as palliative care, using data for continuous quality improvement, and others. We also conduct site visits to better understand what practices are doing and offer support to practices where it's needed. So at that point, I will wrap up. I'm happy to answer questions at the end of the webinar today, and also happy if folks reach out to me through the email address on this slide to answer any questions there as well. Thanks again for having me.